Welcome to the introductory course on the grade approach and summary of findings tables. This course has been prepared and narrated by Holger Schünemann and Nancy Santesso at McMaster University in Hamilton, Canada. It includes a series of training modules, including an introduction to grade and summary of findings tables, how to grade the quality of a body of evidence, choosing outcomes, and how to use the grade profiler, also called GradePro, software to prepare summary of findings tables and evidence profiles. We'll focus on one of the criteria for assessing the quality of a body of evidence, namely inconsistency. When assessing the quality of a body of evidence, remember that there are 4 levels of evidence: 4+, 3+, 2+, 1+, or high, moderate, low, and very low. The criteria mentioned before influence the overall quality of a body of evidence. The basic rules are that if we're looking for inconsistency, we should always look for explanations for inconsistency that we may detect. That can be done by looking at the patients or the population, the intervention, the comparator, and the outcomes. The simple rule is, if there's unexplained important inconsistency, then we would lower the overall quality of a body of evidence. So how do we detect heterogeneity or inconsistency in the results? Simple way to look at this is that when studies yield widely differing estimates of effect, we are concerned about heterogeneity or inconsistency in the results. We consider generally 4 factors. One is the variation in the size of the effect related to the point estimate, whether there is overlap in the confidence intervals. That is, if there is no overlap, then the variation between the study results is more than what you would expect by chance. We consider the statistical significance of the test for heterogeneity and the value of I-square. So the criteria that may lead to downgrading the quality of a body of evidence are that the point estimates vary widely across studies, that the confidence intervals show minimal or no overlap, that the statistical test for heterogeneity, which tests the null hypothesis that all studies have the same underlying magnitude of effect, shows a low p-value, and the I-square that quantifies the proportion of the variation in point estimates that is due to between study differences is large. Another example for large heterogeneity is shown on this slide. This review deals with allergen injection as immunotherapy for seasonal allergic rhinitis, where active versus placebo interventions are compared, and the outcome is nasal symptoms. As you can see, across these 8 studies, there are large differences in the actual estimate of effect, and the confidence intervals are not overlapping between many studies. The p-value assessing heterogeneity is less than 0.0001, and the I-square value is 91.4%. If this inconsistency could not be explained, then most evaluators would downgrade the quality of the body of evidence for the actual effect that is determined here. The question always comes up whether one should not pool such results. However, the other question always remains: what is the best possible estimate of effect? If all of these studies were done in very similar fashion, the best estimate of effect would still be the pooled estimate of effect, but we would have limited or lowered confidence in this estimate of effect. Think of what you would respond to a patient who would ask whether a particular intervention has a certain effect. Your answer would still be that there are several studies, they show different effects, but the best possible summary effect is the one that is depicted here. However, given the heterogeneity that cannot be explained, we have limited confidence in terms of how large this effect really is. The next example shows that the direction of an effect is not a criterion for inconsistency. There are 4 studies. 2 studies suggest a benefit from the intervention. The other 2 studies suggest harm. Previously, this has been considered a criterion for heterogeneity. However, reviewers should move away from thinking of the line of the null effect as a measure for heterogeneity. One of the reasons is that decisions are always made in the context of other outcomes, and that therefore benefit and harm is not determined by the line of the null effect. So in this case, although two studies suggest benefit and two suggest harm, the confidence intervals overlap. The p-value for heterogeneity is 0.68 and the I-square is 0%, indicating that overall there is no important heterogeneity. However, if there is heterogeneity, we need to look for explanations. The questions that we ask ourselves are there different subgroups of patients that experience different effects? Is the intervention similar between studies? Was the outcome similarly defined in the studies and measured similarly across studies? And was the conduct of the studies of similar quality? The question about the intervention includes the question about the comparator interventions. So how does any heterogeneity affect the quality of the evidence? In general, one needs to assess whether the inconsistency in results reduces our confidence in the results that are being obtained. And if inconsistency cannot be explained, or if no inconsistency is detected, it has very different implications for the expression about the confidence in the results. The judgments that we make are the following. Is the inconsistency not serious, which leads to no change in the grading of the quality of the evidence? Is the inconsistency serious and cannot be explained? Then we downgrade the quality by one level. Or is the inconsistency very serious and cannot be explained? Then we downgrade the quality by 2 levels. Consider the following example. The intervention is glucosamine for patients with osteoarthritis and the outcome is pain. A difference that may explain any heterogeneity is suspected on the basis of the 2 available formulations of glucosamine. One is called the Rotter brand, the other in this example the non-Rotter brand. Looking at the systematic review, examining the effect of glucosamine on osteoarthritis, focusing on the outcome pain, we find that the many studies that have been conducted show widely different results in regards to the point estimates of the effects, and for many studies the confidence intervals are not overlapping, despite the overall best estimate of effect of a standardized mean difference of 0.47, indicating benefits or reduction in pain with the use of glucosamine. The test for heterogeneity indicates a p-value of less than 0.00001, with an I-square that indicates important between study differences. While the meta-analysis for pain with all formulations would indicate a moderate to large effect in pain reduction, there is therefore considerable heterogeneity. One way to evaluate the heterogeneity is to look separately at the formulations. This slide shows a meta-analysis of the effect of non-Rotter glucosamine preparations on pain, and it may be suggested that for non-Rotter preparations, there is no important effect on pain, where heterogeneity is less important, indicated by smaller differences in the point estimates of effect, largely overlapping confidence intervals. But what would one present with these 2 examples being present? In a summary of findings table, one could present the outcome pain based on all preparations, where the judgment would be that there is important inconsistency that is labeled as serious, and one would downgrade by 1 level, and one would include a comment about non-Rotter glucosamine preparations that would explain that some of the heterogeneity is reduced if a subgroup analysis was performed. The alternative is to say in the summary of findings table that the results focus on the studies that use non-Rotter preparations, where the inconsistency is not serious and one would not downgrade the quality of the body of evidence, and one would include a comment about the meta-analysis with all preparations, and obviously one would consider the assessment of the quality of evidence according to all great criteria, including precision. The bottom line is that a single table should include either one of these options, but not both. It is also important to remember that hypotheses for explaining subgroup effects should ideally be formulated a priori and should not be based on random examinations of possible underlying reasons for heterogeneity. The next example is from a different Cochrane systematic review focusing on the effects of presenting statistical information. The systematic reviewers suspected a priori that there are differences between healthcare professionals and consumers. While the actual estimates of effect between health consumers and health professionals were similar, indicated by the effects in these two subgroups with a standardized mean difference of 0.66 in the health consumers and 0.65 in the health professionals, there were important differences between studies in both subgroups. In other words, there's considerable heterogeneity in both subgroups, and overall, the heterogeneity could not be explained by looking at the two subgroups, and one would have to make a decision about downgrading the quality of evidence. Question remains how this information should be presented in a summary of findings table. It is possible to present the effect over the two subgroups and label the inconsistency as serious and downgrade the quality of evidence by one level. The alternative is to present the different subgroups in two tables. That is, one would consider a summary of findings table for each group, one table for consumers, one table for health professionals. The heterogeneity is considerable or serious in both groups and unexplained, and therefore one would downgrade for inconsistency for both populations. In regards to preparing summary of findings tables or evidence profiles, one would avoid presenting both subgroups in one of these tables. Finally, a frequently asked question is whether one would downgrade for inconsistency when there is only one study. The obvious answer is that there is no inconsistency as there is only one study, and therefore one would not downgrade the quality of evidence on the basis of only one available study. Some of the reasons for this are that the one study can be a very large study that evaluated all sorts of different populations and provides information and estimates of effect that we can be very confident in. Another reason is to ask where there would be a threshold level for judging inconsistency. Would it be the availability of 2 studies or 3 studies? Once again, the bottom line is there is no downgrading for inconsistency when there's only one study. As in the other modules, we remind you to look for further explanation and examples in the Cochrane Handbook, in particular chapters 9 and 12. In the GRADE Handbook associated with the GRADE Profiler software that can be found easily in the context-specific help section. And if you have any questions, please contact support@gradepro.org. Thank you for listening and participating in this training.